I'm honored to have an opportunity to chair this session and welcome you all to this sixth session, this week-long campaign of DFood International flagship program of DFood, Diabetes Food Awareness Week, which is being running since 7th November till 14th November is going to be the end session, last session. Today we have gathered together for the global meet where all the regions come together under one roof. You are all welcome. We have three renowned speakers. Two of them are award-winner speakers at the Hague, recently had Hague meeting 2023, and one sponsorship talk from Urgo Medical Healing People. I will introduce them, all of them, as we go along the program. We are going to present a short video of less than 3 minutes to introduce the food. So Ali, you can play the video. It is an honor and privilege to address you today as President of DFood International. I speak not only to the diverse and vibrant individuals present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. DFood International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle income countries. As diabetes rates surge, so does the incidence of diabetes related complications, including food related complications, which is our focus of action here at DFood International. Our mission of DFood International is resolved and clear, ending avoidable low-limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare professionals are our only weapons of choice. As I often say, and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at DFood International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of DFood International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of DFood International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, DFood International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Thank you, Ali. Thank you. Okay, so we move to our first speaker. We have Professor William Jeffcott. I have to mention Professor William from Northern University Trust. He's retired, but I never see him to be retired. I liked him to work. First established a specialized food service in 1982. He has always felt strong about the need for high quality evidence to underpin practice and has emphasized the need for systemic documentation of the outcome of routine clinical care. He has involved in many design and conducted of multi-randomized trials and has also been co-author of systemic review on infections, ulcers, treatment, dressing, and classification. And here I will add that what classification we are using in international consensus SINBAD classification, which actually came from him. And we were all part of it. Thank you, William. He has received several awards, including Arnold Bloom Lecture, Diabetes UK, Diabetic Food Study Group Lifetime Achievement Award, ADA Roger Pecora Award. He has served as an editorial board of Lancet and Diabetology. He is currently clinical lead of National Diabetes Food Care Audit of England and Wales and vice chair of ESD Specialist Committee for Health Service Research and Economic. So that co-study which we are doing, he is also part of it. Today's topic is going to talk 50 years in the field of diabetes-related food disease. Thank you, William. Ali, can you play his video? You're welcome.
I am very grateful to you for the opportunity to speak to this very important audience. My name is William Jeffcoat. I am a retired physician from Nottingham, UK. And the title says 50 years working in the field of the diabetic foot. I haven't actually spent 50 years working in the field as diabetic foot, but we'll come on to that in a second. Can I have the next slide? In 1968, when I was a medical student, the first operation I ever went to see was a below-knee amputation for someone with diabetes. The question is, was this a life-changing moment for me, as it was obviously for the poor person having the operation? And next slide is no. I found it sickening, but that was all. It didn't mean I suddenly said, oh, I must find out about this disease. I'm going to change the world. No, it was something that didn't really apply to me. Next slide. I was, however, even though as a medical student, I was very interested in endocrinology as a career, but not in diabetes. And those two professions overlap each other. There are two camps. Some people like endocrinology but not diabetes. Other people like diabetes but not the other forms of endocrinology. Next slide. And of the people who like endocrinology, it already had a long history at the time that I was a medical student, led, I would say without any dispute, by Harvey Cushing, who was a neurosurgeon in Massachusetts General Hospital, undertaken multiple innovations in clinical practice, including operating on the pituitary, of course. He became a frontline army surgeon in the First World War, but he's remembered now for his innovative work, particularly relating to the pituitary and the adrenal. Next slide. Interestingly, when he was an older man, he'd been a lifelong smoker, and he got bilateral peripheral artery disease, and he was told that he had to have a bilateral amputation. He refused and said, I can make it better by stopping smoking. He'd been a lifelong smoker, and he stopped, and he actually saved both his legs. He's an extraordinary man. Next slide. So I was trained, really, my main inclination was into what I call the Cushing's aspects of endocrinology: pituitary, thyroid, adrenal, etc. But I was then appointed as a general physician and endocrinologist in Nottingham in 1979. And the trouble was that the appointments committee made a mistake, and actually so did I, because I'd only ever done one diabetes clinic in my life at a very junior level. And the result was, since I'd got the job, I had to learn very fast. Next slide. Within 3 years, I mastered, well, not mastered, but we had established a functioning diabetes service with the usual supporting staff. But the aspect of diabetes which became clear to me was not well covered at that time, 40 years ago, was actually diabetic foot disease. There were very few services anywhere in the world. There was no template for good practice. There was no training. Everybody had to pick it up if they chose to as they went along. Things began to change, however, within a very few years, and specialist services then began to evolve in both UK and other countries, obviously. Next slide. And the new service for foot disease involved coordinating the work of a number of different clinical staff, physicians, nurses, podiatry, the help of radiology, microbiology, orthotics, and orthopedic and vascular surgery, such as we know today. Next slide. But one of the things that was staggering in the 1980s was how little research had actually been done in diabetic foot disease. And I want to enlarge on this a little bit. Next slide. I borrowed the slide from another talk I gave not so long ago about the numbers of papers on people on diabetic foot ulcer disease that are recorded on PubMed. PubMed started in 1947, which is actually the year I was born, so it's pretty ancient. And I then started, as I said, in my last post in 1979. Next slide. And if you look at the numbers of papers published in PubMed on diabetic foot ulcers over, say, 10-year intervals, more or less, as I've done here, you'll see that in 1979 there are only 37 papers on diabetic foot ulcers. By 1993, it was 170. 10 years later, 20 years ago, it was 370, then 820, and then recently, just a pathetic 1,600 publications. Now, what's the relevance of this? How does it compare with other diseases? Next slide.
2-minute ordeal for
More
my
recently, we've learned, as shown here, that diabetic foot ulcers, the cost of diabetic foot ulcers is greater than the costs of carcinoma of the colon, breast, and lung put together. So these obviously very important diseases actually cost less to the health service than the management of diabetic foot ulcers. But how do the numbers of publications compare? Next slide. And you can see that when we started, the total number of papers was far, far higher. This is early 1980s, far, far higher, sorry, 1979, far, far higher than it was for diabetes. And then at each 10-year interval, as listed here, it goes up astronomically. Next slide. And you can see that by 2022, the numbers of papers for these three cancers totaled 70,000, compared with just 1,600 for diabetic foot disease. And I think that is actually a show-stopping statistic. Next slide, please. So if we were to do more research for diabetic foot ulcers, which we haven't done so far. It's quite an amount of industry-related research, but other research driven by the professionals, if you like, if I can put it that way, which is a bit clumsy. Well, there are different fields whereby we could explore more about diabetic foot disease. Have the next slide. The first one is if you look at the pure science of diabetic foot ulcers, the mechanisms whereby ulcers form and fail to heal. These are mechanisms at tissue level, at cellular level, molecular level. And this is obviously a very, very important area which needs to be explored but has hardly been explored. And then similarly, when you have identified these different mechanisms, what is the effect of different interventions and treatments which could be used on their function? Next slide. But we could also plan a strategy, programs of research for clinical management of individual people with foot ulcers. Look at prevention. Obviously, there is work like this going on. The prevention, whether it's the person who themselves realizes they're at risk or their carer, or it could be research into active disease of active foot ulcers. How they're best managed, how you manage care, how you manage the person, and when it heals, a prevention of recurrence. So those are two broad groups of research which we should be thinking of doing more. The next slide, is the effectiveness of care, not so much as in individuals, but in populations. So should we start looking at whether they're racial populations or whether they're social populations or whether geographic populations or related to countries? There are lots of things to be studied which will give us greater clues into the management, causes management, how to make people better. We can document incidents, we can document outcome, we can compare different management outcomes between different populations, different countries, etc. Regular reviews of incidences and outcomes are very important, and then we can review, as time goes by, we can review progress of different research that's gone on and link it to cost, say, or improvement of management of existing services. Next slide. And the fourth group of research which I draw attention to is not so much what we're trying to do, but the method which needs to be of it, is the need to record detail as part of routine practice. It's no good doing a busy diabetic foot clinic, seeing 40 people in the space of half a day, and then going and having a cup of tea and the rest. You have to record what you've done, because unless you systematically record what your approach has been and how effective it has been, you will never get any better, and nobody will learn from you. And that is why recording of clinical practice, I think, is a key feature of future research. Now, I've been very fortunate. You'll see it written on the bottom of that slide in red, National Diabetes Foot Care Audit, which is an audit which was set up by others, particularly Bob Young in UK, in England and Wales, and I was brought in to help with looking at the foot care activity, if you like, audit the measurement of activity for people with foot care, and this is in England and Wales. And now I'll show you some slides, but they are probably a bit, I don't know, that won't fit in very well. But you can just Google National Diabetes Foot Care Audit, and you will find immense details that can be gleaned from the systematic collection of data during the course of clinical practice, in this case across England and Wales, and I'll show you some numbers in a second. Can I have the next slide? And one thing that you could look at, and which we have looked at, and this is readily available online, is looking at the time that elapses from the start of an ulcer to the time that it's first seen by a foot ulcer person, nurse, podiatrist, doctor, whoever it is. And you will see, if you go from the top to the bottom, that the categories, the people are either self-referred because they've had one before, say, and they ring up and say, oh, my leg's bad again, or they are referred to be seen in a specialist clinic, and they are seen in less than 2 days or less than 2 weeks, so the second and third horizontal bar, or it might be less than 2 months or greater than 2 months, so going downwards. And you can see that as you go down, if you look at the right-hand side of each bar, the darker color, that is the severity of the ulcer when first assessed. So the longer someone waits, the more severe the ulcer is before treatment is initiated. Next slide. And this is, again, difficult for you to pick up, but again, it's available online. Very, very similar, and you'll see there's 5 bars there, going from people who are self-referred, people who are seen less than 2 days, less than 2 weeks, etc. And you will see that when those groups have been examined, we're trying to see how many are actually cured, in the sense of being still alive, but without any ulcer on either foot anywhere at 12 weeks. So being alive and ulcer-free at 12 weeks is one of the outcomes which we use. And you can see again, if you look at the bottom part of the slide, that the longer someone waits before they're seen by someone who's a specialist, the less the chances of their being healed within 12 weeks. Now, these sort of data are crucial because they should change the way we work. Next slide. Now, and this is interesting. This is again the same data from the NDFA. It's the third of 3 slides, and I'm not going to show you any more. And you will see that between 2014 and 2021, despite COVID, the specialist services which were participating in England and Wales actually reviewed 97,000 people with a foot ulcer, presenting with a foot ulcer. They reviewed and they recorded. And these 97,000 had 108 ulcer episodes. Now, the results here are actually branching out into something that's you can learn, you see. So if you have a system whereby such large numbers of people are being reviewed, you can start to pick up things that you wouldn't suspect. And in this graph, you'll see that it says heart failure at the top of the figure, going up from 12% to 18%. And then a little bit lower down, there is a number of people with heart attack and stroke going up from 5% to 8%. And what this is showing is that these are people who are presenting with a diabetic foot ulcer, but who had been admitted to hospital, and which was separately recorded, with heart failure in the year, 12 months before their foot ulcer started. Or people who had a myocardial infarction and were admitted to hospital in the 12 months before they present with a foot ulcer, and then stroke. And what this is showing is not so much a causative mechanism, but it is showed us that the population we're studying is changing for whatever reason. It could be more people are participating in the audit. And these people are referring different populations of patients. And so these sort of data are very, very important in helping you analyze the other results which you're looking at. Next slide. So I've said we do need desperately more research in diabetic foot ulcers. And we need to do that in one of the groups I said. We could look at pure science, cellular level if you like. We could look at management of individuals. We could look at populations, groups of individuals. And then analyze the implications of all for clinical carers. And the key to this is actually recording clinical detail as part of routine practice. Next slide. I mentioned a short while ago the individual specialties which are involved variously in the management of diabetic foot ulcers, and the close liaison between these individuals is crucial, whether they're community, hospital-based, whether the patient is, the renal team, whether they're under care of vascular surgery, etc. It's all straightforward. Next slide. But there's a problem, and that is that doctors are not good team players. Either doctors or the structure of the way in which healthcare is delivered. And I don't know why this is. I don't know why we have a tendency, not always, there are obviously some groups who work fantastically well as team players, but there are an awful lot of people who work on their own, in their specialty, as it were, without involving others. And I do really think it is a potential major weakness in the delivery of healthcare across the world, and it's one that people need to ponder. Next slide. And so, in conclusion of my 50 years work on diabetic foot, which weren't 50 years work on diabetic foot, but if you like, thoughts from 50 years training, the causes of DFUs are multiple and complex, more complex than most other clinical conditions. They're common and they cost an awful lot. Most of us understand all the mechanisms involved. Sorry, let me start again. Few of us understand, few of us have the insight into all the processes which are involved and the barriers which have to be leapt over in order to ensure the best outcome. I've mentioned the fact that we're not good team players. Maybe I've overplayed it, I don't know. But we have an awful lot to learn. It looks as though we've run out of slides. So at that point, I will stop. Thank you. Oh, I've got my next slide. This was my last slide. Talking about 50 years working in the field of diabetic foot. But I wanted to add a comment about today, the 12th of November. Next slide. Because this is, in many countries of the world, Remembrance Day. Remembering the problems of man's inhumanity to man. And it just occurred to me that the things that we've all been hearing about over the last years, weeks, actually are causing enormous amounts of suffering, and, if you like, also reenacting the effect of man on man. And although we're talking about diabetic foot ulcers as an individual, I just wish to say I sincerely hope that all the current crises are soon going to come to an end. Thank you.
Thank you, William, for a great talk. William, if you noticed that William actually did not list his great achievement done through 50 years, and he talked on the things that still needs to be done and try to help new people who are coming in the field of diabetes-related food care across the globe. That's really great and humble of him. He also emphasizes on the specialist working in the team, which he said that we do not have a good team players, we do not work pro. That's really great. Thank you very much once again, William, for a great talk, really. We really appreciate. Thank you very much. Vijay, you have a hand.
Yeah, Professor William, it was a fantastic lecture as usual. You talked about the NDFA data on 97,000 patients. Do you think that the DFoot International has started something and published about fast track pathway? So do you think that the implementation of such a fast track pathway, which was designed by the DFoot International and implemented in Italy, will help the NDFA data to be reversed a bit and improve the hospital admissions and mortality from DFMs? Thank you.
Yes, I think it's a fantastic initiative and one of many that could be done. And it's a matter of different groups, different countries, different populations within any one country agreeing what they want to measure and then trying to demonstrate that no matter what changes have been made, they can show that things are getting better or are not getting better. And so I do think the DFoot International initiative is ever so important.
Thank you, William. Anybody else wants to talk?
Yes, please.
Yes, Jamil.
Professor William, in the beginning of your talk, in the first few slides, you were touching on one point, having independent studies done by healthcare professionals, by doctors, not industry-driven. My question is a little bit tricky because I feel it in my own practice after 30 years experience in diabetic foot. Many times I feel that the studies driven by industry, I don't want to say I overdoing things, but are driving us, are channeling us toward more consumption of expensive material that we can very well do or avoid using and getting excellent results without using these devices or machines and without feeling guilty. Because nowadays, when we have studies saying that this machine, ultrasound, for example, or hyperbaric, local hyperbaric oxygen therapy, or such and such negative pressure, platelet-rich plasma, radio frequency, and other devices, if we don't use them, we feel guilty because maybe we are compromising with our patients. We really need individual healthcare-driven studies. So I support very well your point, and I feel it in my own practice. But the real obstacle, the real barrier is that we don't have enough funds and we don't have some common background to conduct large studies. If you want to do it on individual basis, they will be weak studies. Someone, and this is now I am addressing Dr. Abbas, some organization has to do a big thing, joining the efforts of multi-centric individuals, of multi-centric wound clinics, in order to channel and to obtain a high number with reliable outcomes and having excellent statisticians working on, so that we conclude either that we definitely need all the things marketed by industry, or we can do something else or coordinate efforts. So your word, what you said in the beginning of your conference, this is what you were alluding at in a very decent and polite way, not the way I am just opening it up.
Thank you, Jamil. Thank you, Paul. Yes, William, you want to add?
It's a very difficult issue.
Yeah.
And I'm sure we all agree that we do need to have a lot of more research on clinical factors, things that need to, there are all sorts of things which we can explore, whether it's time to first assessment, whether it's who assesses, how quickly you do this, how quickly you do that. So and all of those should really be standardized. I think the International Working Group on the Diabetic Foot, which is the group that meets each 4 years, that met in April, May this year, and then is looking specifically at this in the sense that each time they're looking at all the data that has been accumulated, and they are grading the quality of the data to try and see what is good data which might be helpful to everybody, and what is perhaps not quite so good, even though it might increase the income of industry. I'm not being critical of industry. They've obviously got to maintain an income. What we want to do is to have an effective meeting between the two. But if you look at the IWGDF data, it is incredibly detailed, looking at every accepted systematic review that has been done since the last review 4 years earlier. And so I really would urge you to look at that. And to be honest, looking at all the published data, there are very, very few which are now are available, showing an effective result from the interventions which are being promoted. I'm not antagonizing, I hope I'm not being critical of industry, because they should be our partners. And they are, in many places, providing a fantastic service in providing funding for nurses, say, or other people contributing to foot care. But on the other hand, we should not swallow without criticism the interventions which are being recommended for our use. So you have to be very, very careful. And there's no better place to start than the IWGDF reports, which were published earlier this year.
Thank you, William. Yes, Wilma, you are first on queue.
Yeah, hello, thank you. First of all, I have to say that I would like to congratulate Professor Jeffcoat for the talk. I enjoyed every moment of it, as always, and I was deeply touched by the way you finished it. But my remark was on what Jamil Halabi said about the data and industry-driven data. I think that we could do a lot if all the data which we get at routine clinical work would be kept in databases which could be then properly analyzed. In fact, we are in the middle of a gold mine. We just cannot collect what we have because keeping everything we do on sheets of paper means that the data are lost. So maybe analyzing what we have can get lovely results in particular in the field of prevention. If we analyze the data from preventative foot exams, we can get many new hints what to do and how to do.
Thank you, Wilma. Thank you for that comment.
Well,
Yeah, Linda is next.
Okay, thank you very much, William. I just would like to make a comment and say that you really are an inspiration to all of us. We have been having the opportunity to welcome you here in Brazil, and you really, I think you really gave us a very important legacy along all these years. And in your last part of the talk, I saw how you emphasized this very big problem that we have to identify the comorbidities that these people with diabetic foot ulcers have. And I think this is a very important task because still many people see the patient as only an individual with a lesion, with an ulcer. But in fact, we really miss this holistic approach because the person really has a very high risk. And if we don't focus on this aspect, we will still miss people to death and to other things that we know from this devastating complication. So thank you again for being a leader, for being an inspiration, and also for bringing us a reflection with your last slide about what is going on in this world. Thank you very much deeply.
Thank you, Linda, for the comment. Yes, Professor Shakawi, you are next. And then
yes. First, thank you very much, Professor William, for the very guiding lecture, very informative. And just I want to mention something. I have experience in Chennai with Dr. Vijay Institute for Diabetes. Really, they are doing marvelous work. They are starting from educating the patient and his relative through all the treatment till manufacturing the food specialized for that patient with the minimum requirements, with very not rich area, with the minimum material. They are doing great job, really. All I think that we need is not much money or funds, but more cooperation, more disciplined work in research. If you propose some research document and chart to fulfill it, and all the physicians can give the data about that, so that we can collect very good data, very scientific data, and give very nice results and decisions and produce papers with evidence-based medicine and with good percentage of everything. Thank you very much.
thank you, Professor Shakawi. Yes, Memuna, you are last.
Thank you, Abbas. Thank you very much, Professor William, for this very inspiring talk. You rightly mentioned the fact that medical doctors are bad team players. I thought this was specific to our low resource settings, maybe due to lack of resources. I'm surprised to hear it from you. Would you say that this is where we fail most is in communicating between us, or communicating with patients, like raising awareness, or just making multidisciplinarity really effective? I'm a bit confused. Thank you.
William, you want to comment?
Yes, it's difficult to give a straightforward answer. It's perhaps just to emphasize the fact that the management of these highly complex conditions, which is what we're looking after, requires us to work together closely with other people, whether it is community staff, whether it's surgeons of one form or another. And that should be our target. I'm not trying to say, not want to put a negative side on it, but really just to keep that in mind, that we ourselves on our own can often not provide the sort of care that every person needs. And we always need to be thinking about working closely with others.
Thank you, William. Okay, President-elect has raised his hand. So yes, Harry.
Thanks, Avas. I think I don't have that much to say, but to say that, William, as wonderful as it is, I think from the time that we had trained the foot trainers many years ago until now, I think your legacy supersedes you, and very happy that basically, you have shown the disparity that we all have seen. Basically, what they call it, everyone says malignancy is the main problem, but DFU is the one which is long term and it's recurrent, and we are managing that. But just one thing to chart, since you have got 50 years of experience, more than any one of us here, I suppose, I would like to ask, like now you see DFU International, it has got lots of MOUs. We are now working with the IDF through our good friend Linda. And then we're also working, with IWGDF and all that. How do you see us basically after this? Because I think one of the final things to reach is actually the WHO. Because I remember last year when they came out on diabetic recommendations and all that, there was actually no mention of DFU at all. So finally, we all had to write in from all the member countries asking them, please put diabetic foot there. That's supposed to be, 85% preventable. And that was since 1998. So it should be there, actually. See? So what is your suggestion? I always believe that, from great teachers, we get great advice. And it's good to hear from you. What do you think we should do next?
I'm not, I might have been working in this field for a long time, but doesn't necessarily mean I was a very good politician. In fact, in many ways, I was a very bad politician. And what you need is advice not from me, but from other people who are better at it, if you like. But the message is that we all agree. And we do need to emphasize that this is a major issue. And to be fair, I think a lot of groups are repeatedly emphasizing the importance in terms of cost, well-being, and the rest of it. And we just have to keep doing that. And in the end, I think the message will get across.
Thank you, William. Okay, the last question. Yes, Mariam, your hand is up.
Thank you so much. Thank you, Dr. Jeffcoat. Amazing talk. And thank you for the body of your work and your continued advocacy. One of the things that if we as a global community, building on what Harry mentioned and what you just talked about, if there is a policy priority focus, what would you recommend? I think governments are aware or are starting to develop the awareness that this is a complex problem, that this needs to be addressed. But they're looking at a policy priority focus. What would you say that would be?
I think whatever it is, it needs to be something which incorporates a systematic collection of data, which should obviously be simple for people to do to ensure that the collection is more or less complete. Amputation, for instance, of course, has been long used, but the problem of amputation is that not everybody has an amputation, and it's a treatment. It's not actually a way of getting of treating the disease, if you know it. Well, I can't finish the sentence, but you know what I mean. Amputation has the advantage the data are already collected, but there are other outcomes which might be better. And for instance, the one that I mentioned earlier, the 12-week outcomes of someone being alive and ulcer-free is a very good one. And it wouldn't involve too much time on the part of clinicians to actually complete the simple ticks that you'd need for those sort of data. So I think there are strategies. It's an enormous task, but it doesn't mean that we shouldn't try.
Thank you.
Thank you, William. It's all nice thing has to come to an end. It was really great, very inspiring, and the whole globe is listening to you. I don't know. Thank you very much from bottom of my left ventricle. All of us, we really enjoyed it. Thank you very much, and we look forward to have another webinar. Please, you saw how people are enthusiastic. I mean, there are so many other questions I cannot even go because the time is not in our favor. So in future, maybe we will invite you again. Thank you very much, William. Thank you.
Thank you.
We move to another talk, another speaker. It's a sponsorship talk sponsored by Urgo Medical. And it's Professor Jose Luis. We all know him. He's a lecturer at the Complutense University, Madrid, Spain, head of Diabetic Food Unit, director of Diabetes Foods Research Group at the university, research institution at the St. Carlos Teaching Hospital. He's a board member of Diabetic Food Study Group Europe. He's a chair of Diabetic Food Committee, EWMA, and past president of D-Food International. Yes, we have his video. So Ali, can you play his video?
Hi, everyone. Thank you very much for inviting me for joining this symposium, and especially it's very, very important for me joining again the Diabetic Food International Awareness Week. So for this reason, thank you, Urgo, for inviting me for talking about the treatment of diabetic foot ulcer. So I'm going to share my screen for introduce the topic today that are focusing in the management of diabetic foot ulcer around the world, and especially how to get more ulcer closer associated with selecting the right local wound therapy. So let me introduce myself very briefly. My name is Jose Luis Lázaro Martinez. I'm full-time professor in Complutense University in Madrid, Spain, and I'm the head of Diabetic Food Unit and the director of research Diabetic Food Group in our teaching hospital and the university as well. My pleasure as well, because I'm one of the honorary president of the Food International and a former diabetic food president during the 2019 and 2021. So without any doubt, I think that the majority of you are very aware about what is behind diabetic foot disease. The figures are scary when we are going to the literature, and we can realize that more than 6 million ulcers are developing annually among the world in patients with diabetes, and then every 19 seconds, one lower limb amputation is underwent in a patient with diabetes among the world. We can say that this is a very serious disease, and it's very important to put the spot over this kind of patient in order to reduce the complications that are associated with diabetic foot. The main problem sometimes is thinking that diabetic foot is only an ulcer. And the reason, or when you are thinking that diabetic foot is only an ulcer, probably you are only focusing in local care, and this is a big mistake. Behind this kind of patient, there is a patient with a lot of comorbidities, especially cardiovascular comorbidity, renal comorbidities, patient with anemia, patient with neuropathy, and patient with ischemia. For this reason, I used to say that diabetic foot is a sign of a serious complication in a patient with diabetes. So that means that when a diabetes patient develops a diabetic foot, this is a marker, this is a sign that this patient has a complex comorbidities around him. For this reason, there is not only one doctor that can manage this patient regardless the specialization, because this patient needs a multidisciplinary team, because it's necessary to put in place the standard of care that are focusing in the offloading, focusing in the management, the ischemia, the infection, the diabetes, and the complication around the diabetes, the comorbidities, and focusing in the local care at the same time. The problem with local wound care is that the main pillars of the local wound care is debridement, without any doubt, and the recommendation behind the debridement probably is the SAR and surgical debridement. Offloading, there is an important matter. Indeed, there are one charter of offloading, including in the last edition of the International Working Group Diabetic Food Guidelines. And another important pillar for local wound management is the local dressing. When we are using or when we are putting in place this standard of care, there are some main objectives that are around our thoughts that are mainly getting more patient healing in a less time, avoiding lower limb amputation, and at the same time decreasing mortality associated with increase the quality of life of the patient, and at the same time avoiding the new ulceration of the recurrences with the prevention of the secondary prevention. But when we are looking back about what is the reality in the clinical practice, it is very disappointing and sometimes it's very frustrating, because looking for the number, for the figures, you can realize how the majority of the patients are treating only with neutral dressing. And this neutral dressing in some specific condition are not working enough or are not working well. Perhaps this is the reason why 70% of diabetic foot ulcers are still open after 20 weeks of treatment. And perhaps the level of the awareness around the local care and specifically around the dressing is not the same comparing with the awareness around the revascularization of the treatment of the infection of the management of the diabetes. But without any doubt, remember that this is one of the pillars, including in the standard of care, and for sure the selecting of the right dressing matters when you want to improve the patient outcomes. So the question is there any solution? We can say that, thanks God, yes, there are a solution, and these are a solution and that has been proven according with the evidence, and there is some recommendation for using some specific dressing in the management of diabetic foot ulcer. This recommendation is coming from one strong RCT that has been published in 2018 in Lancet and Diabetes Endocrinology Journal, and is behind the Explorer study. The Explorer study demonstrates in a RCT kind of the study that the use of the octosulfate impregnated dressing, that means Urgo studies, the commercial brand, give better outcome in the percentage of patients with the ulcer healing and with less time, approximately 70% more that patient healed in approximately 60 days less when you are treating patients with this kind of dressing. One of the most interesting points behind the Explorer study is that the inclusion criteria selected neuroischemic diabetic foot patients that are probably the most complicated patient to get healing, and that's probably the patient who has associated less likelihood to heal. So after the publication of the Explorer study in 2018 so far, there are a lot of milestones that this technology has achieved in different recognition. For instance, it has been recognized in Spain, and it has been recognized in France with different price and recognition with the new technology and with advanced technologies with the Minister of Health in France and in Spain. But for me, the most important milestone and one of the most important milestones is that this dressing of this therapy, better than dressing, has been included in the NICE guideline recommendation in 2019, and it has been included as well in the same year, in May of 2019, in the International Working Group Diabetic Food Guidelines recommendation as the first dressing that has been included in this kind of guidelines as like a therapy for management diabetic foot ulcer. And we can say that this recommendation is still including in the last update of this guidelines in 2023. So the reason why this technology has been included in this group of these robust guidelines or guidance is because there are a lot of studies behind this technology. There are a lot of evidence behind this technology, from the very base of the pyramid, from the top. So that means from the case study and the opinion of key opinion leader to the meta-analysis and systematic review. And all this kind of evidence is supporting the use of this technology in patients with diabetic foot ulcer, and specifically in patients with diabetic foot ulcers with some guide on ischemia. That's mean neuroischemic diabetic foot patient. But in order to summarize all the evidence that are behind this technology, UrgoStar, I summarize in different insights in order to give you some important information behind this technology. Remember that Explorer study demonstrates that this is a good therapy for treating neuroischemic diabetic foot patients. But at the same time, this study demonstrates that the better outcome happened in patients who young ulcers, so that's been with less duration of time. And for this reason, the first insight is the sooner the better. The sooner to use the technologies, the better outcome you can get in your patient. And this has been demonstrated in another publication published in some time ago, approximately 1 year ago, after the Explorer study, in which we demonstrate that when you are using in wounds with less than 2 months of wound duration, you can reach more patient healing when you are comparing patient who has an ulcer with a longer duration of time. So the main recommendation is to use this therapy, and especially as a first line of treatment in patients with neuroischemic diabetic foot ulcer. Additionally, in another observational study, including a lot of patients, in this study has been including more than 2,000 patients, around 800 patients with diabetic foot ulcer, it has been recommended to use this technology, UrgoStar, as a first line of treatment, especially in patients with young ulcer, because you can get better outcomes. So remember, the sooner the better means that specifically in diabetic neuroischemic ulcer, the impregnate octosulfate, Sucrose octosulfate impregnate dressing is the first line of treatment on this kind of patient. So the second insight is regarding the cost-effective solution. And this is very important because sometimes when you are facing with your manager about the necessity to buy this kind of technology, the people used to say, okay, this is a very good technology, there is a robust evidence behind, but it's most expensive comparing the natural dressing, and it's right. But the problem is focusing only in the price per unit and not in the price per therapy. And you have to think in the whole treatment. And associated with the use of UrgoStar, it has been demonstrated that you can reduce healing time, you can reduce nursing hours, you can reduce the number of complications, and you can reduce the number of the dressing chains. And according with this, you can get better outcome with the less cost. And this has been demonstrated in different independent cost analysis studies published in different countries, like you can see different here in UK, in Germany, in France, in China, in Canada, in Czech Republic, and in Spain. So the other important insight is that this robust evidence is supporting the inclusion of this technology in 2 important guidelines. The first one, I mentioned it before, the NICE guidance. The NICE guidance including UrgoStar recommending to use for patients with venous ulcer and diabetic foot ulcer, regardless what is the main etiology. That means regardless that the patient has ischemia or not. This including as well for treating patients with diabetic foot ulcer, neuropathic one, and at the same time neuroischemic one. It's got included in 2019 and is confirming in April 2023. And this is supporting but mainly 3 systematic reviews that are supporting the effectiveness of core of the use of this technology, and especially after the result for the Explorer study. At the same time, this technology has been included in the guidelines for the International Working Group of Diabetic Food. The first time that is included is in 2019, that recommending the use of the Sucrose octosulfate impregnated resin as the standard of care for the treatment of neuroischemic diabetic foot ulcer. So that means that when you have a patient with diabetic foot ulcer with neuroischemic condition, the first line of treatment should be this technology. That is not optional, should be, because there is not only alternative so far to replace this selection. And this is why the stronger evidence demonstrate the benefit to use this kind of technology in neuroischemic diabetic foot ulcer. In the current guideline in 2023, the recommendation is keeping inside the guideline, but at the same time, the recommendations say that you have to consider to use this kind of dressing after 2 weeks period in which the standard of care is not working well. This is very important concerning the first insight. Remember, the sooner the better. So that means that it's very important not wait too much time for seeking or for looking that the ulcer is not improving. Sometimes you can receive a patient with 5, 6, 8 months of ulcer duration, and with receiving different kind of therapy, especially neutral dressing, and then the people start to use this technology. And in my opinion, this is a mistake, because you can get better outcome if you can use as a first line of therapy, and especially in neuroischemic patients. So remember, that is the recommendation behind the guidelines. So why these recommendations are coming from Urgostar for this dressing? The first reason is because this therapy has the high level of evidence necessary for being included in the International Working Group Diabetic Food guideline. That's mean randomized and controlled trial. The second reason is because it has been demonstrated a significantly faster time to heal comparing to other dressing, and specifically neutral dressing. So remember that majority of our patients are receiving just neutral dressing, and sometimes it's not enough, and especially in neuroischemic condition. But sometimes in another kind of patient with neuropathies one that are not responding to the neutral dressing. So remember, sometimes you are using the best technology at the best advance in other kind of fields, for instance, revascularization or treatment of the infection, and sometimes you are selecting a neutral dressing that are not enough for the patient healed. But another important thing is the cost effectiveness, because it has been demonstrated that if you can reduce the time to heal and you can increase the number of patients healed, of course, this is a cost-effective therapy for treating diabetic foot patients. The other important insight is concerning the improving of the microcirculation. And this is a very interesting finding that it has been demonstrated some years ago for our group. And this is a pilot study that we published in 2020 in the International Journal Lower Extremity Wounds, in which in this pilot study, including 11 patients, demonstrate how patients who are receiving the therapy of Urgostar improving his microcirculation status, and improving especially the microcirculation status measuring by the TCPO2 levels after the therapy of this kind of dressing, comparing the day 0 and the wound closure. You can see here the tables, significant difference from the beginning of the therapy and at the end. But we following to study after this pilot study, and we including more patients, in this case 50 patients, and we demonstrate that the results are concordant. And according to the follow-up of the patient are increasing significantly the level of the microcirculation according to the TCPO2 in patients among the or within the therapy, and especially when you are starting the therapy and when the patient has or get the ulcer healing. But following with this finding, we want to compare the result in patients who received the therapy with Urgostar and those who are receiving neutral dressing. And comparing the data, we can realize how the patient who received the Urgostar therapy, having at the end of the treatment, not only better TCPO2 level, not only an increasing of the microcirculation, but at the same time, the most important thing is that this microcirculation is keeping among 12 months after the ulcer healing. This is very important, and how in this group of patients, this increasing of microcirculation is associated with less recurrences when the patient has healed. So that means that this therapy is not only good for getting more patients healed in the less time, but it's good as well in improving the microcirculation status of the patient, and this can reduce or can decrease the number of new ulcers or the number of recurrences in diabetic foot patients. So remember that it's very important to select the right therapy in local care, and remember that perhaps we had to change our mentality, not only about the wound care, but about the wound treat. So that means that it's better to treat the ulcer rather than to care the ulcer. And it's important to realize the majority of us are caring the ulcer, but are not treating the ulcer. But the main important message that if you are using this technology, you can treat the ulcer and you can get better patient outcomes, and especially in patients with diabetic foot ulcer and neuroischemic diabetic foot condition. Thank you very much for your attention, and bye-bye.
Thank you very much, Jose Luis. And it's very nice, very precise, to the point, in a very short time. You gave us a very good overall. Thank you very much. I mean, it was really wonderful. And it's also nice you are here. You are most welcome. It's open for a discussion. Yes. Anybody wants to ask any question? No. Yes.
Dr. Jamil. Yeah.
Yes, Jamil. You are mute, Jamil. Yeah.
Okay. Thank you, Professor José Luis, for a very interesting talk. And to tell you the truth, in the beginning of the talk, I was a little bit was having some reserve, because we are talking about progress and devotion for diabetic foot, and at the same time questioning if all the industry is doing a good job and for the sake of the patients, or for other things. But really you succeeded at the end of the talk to be very comprehensive and very convincing. But nevertheless, I have only one single question. How could a local treatment provide the diabetic foot, the neuroischemic foot precisely, with a long-lasting improvement of the microcirculation? I can understand a short-term improvement in microcirculation, but a local treatment providing a long-term improvement in microcirculation is really something to think about. So can you help us?
Yeah. Yes, thank you. So first of all, I'm happy to be here. I'm happy to join another TFUS activity. Very nice to see a lot of friends around the world. So happy. So thanks, Jamil, for your question. Very interesting indeed. And indeed, I think this is the key point, because the principle or the principle that are included in the dressing. So that's mean the sucrose octosulfate is coming for other drugs that are using it in other disease. So especially in oral ulcers and in gastroenterological, and especially in gastric ulceration as well. And in this previous study, the previous researchers demonstrate the ability of this drug to improve the new vessel formation. That means to improving neoangiogenesis. So that is just my theory. So of course there is not a study demonstrating that this growing of the new vessel is the reason for increase the microcirculation. But if we are thinking in this, it's logical to think that's probably behind this increasing of the microcirculation is the new vessel formation. So that is my opinion, and I think this is the key point. So we can say that probably there is some benefit in the neoangiogenesis, especially in neuroischemic patients.
Thank you, Jose Luis. Thank you. Anybody else? How would you, Jose Luis, compare with neutral dressing in the healing?
Yes, so I think this is the beginnings of the history. So if you say, or you are looking back for the Lancet study, this dressing is comparing with the same dressing without the drug, and I can say that is the beginning of the history. But the thing is that is my personal opinion, right? But I think that many people can agree, because in general, when you are treating, when you are approaching this kind of patient, you are putting a lot of resources behind this: revascularization, surgical options, operating rooms, hospitalization, a lot of resources are around this. And at the end, we are sending the and sometimes the patient is going back to the hospital with a complication, infection, or worsening of ischemia. So I think we need to reconsider, or at least to have at the same level all the treatment that we are putting in place with the patient. So it doesn't make sense that you are spending, I don't know, 12,000 euros for revascularize a patient, and at the end you are discharging the patient with a neutral dressing that is 5 cents. So that is the problem. So perhaps we need to implement better this therapy, and we need to include in all the approaching that we are doing currently with this kind of patient.
Thank you, Jose Luis. There is a question from Argentina. Can we use treatment over the tendon?
So primarily no. So that's mean. So we need to have covering the deep tissue. That's mean bone, tendon, joint, and muscle. So that's mean that if you have a tendon exposed, you have to prepare before to apply this technology. And there are a lot of options, but it's not demonstrated that it's able to cover and to create new granulation tissue over deep tissue. So primarily, no.
Okay. Thank you very much. Yes, Zaid, you've raised your hand. You are mute.
Oh, yeah. Thank you, Jose, for a lovely talk. I just have a quick question regarding how you can see use of this technology in the lower income countries.
Yeah, without any doubt. So first of all, good to see you, Hahid, and good to see you that you are well. So always happy to see you. So this is another barrier, of course, but there's another barrier following for other kind of therapy, because the main problem that we have, so you know, DFUT has the big duty to implement recommendation coming from the guidelines, and the problem is the majority of this evidence are producing in the Western country. So that's mainly Europe and United States. And you have to implement around the world. So that is a limitation for sure. So my opinion, so first thing, awareness. So we need more awareness about local care. Probably you can combine your manager of the hospital to implement a new guidance for revascularize the patient. So probably you can combine, but it's hard to combine to implement a dressing, because the people has in the mentality, okay, a dressing is a tape. So that it doesn't matter that you are using, right? So first time, awareness. The second thing is the price of the technology is like everything in the world. So if we can spread the use of this technology among countries, I can expect that the price is going down. right? So that is true. So probably this technology has to cover all the expenses behind it, and especially putting in place this big RCT and all the technology that the laboratory has put in place. But if we are using more and more people, probably the price is going to be less in the coming year. So this is the two only ways to do. And especially I can say that the third thing is probably the low-income countries can ask these companies to perform specifically studies in those countries. Very interesting, because imagine you are doing in Pakistan and randomized control trial, and probably you have a big argument with your policymaker, right? So, and you can extend to the other countries. It's not too much complicated, but asking the companies, please, we need to implement these health apps in something to help us is to create new evidence in low-income countries, without any doubt.
Thank you. Yes, yes, Linda, you have a question.
Oh, yeah. Thank you very much, Jose Luis, for another great presentation. We just had this week here in Brazil during our Awareness Week a very important work that Dr. Glayton is doing in Itabuna, a very, I would say, middle city in the interior of Bahia, which is a very big state in the northeast of Brazil. And Urgo has been a very good partner in this approach, making this liaison with the primary care, attention with the secondary care. And he showed some of the preliminary results in this important work that he's doing there. I wonder, Jose Luis, if you, of course, I know it's that it will not depend on you, but anyway, if you as a leader of many of the good publications with these dressings, this technology of the company, if you could try to persuade them to spread out this strategy, because we are going to try to do this here in Brazil with a work that we are planning to do with the National Council of Secretariat of Health. But I mean, you see, at least in our region, as far as I know, only Brazil and Chile have the technology. And but I mean, in terms of education, of approach, and especially to teach the primary care people to really do the proper job, so we can really avoid having this delay of referral, and of course we can perhaps avoid the terrible results that we still have in concern the diabetic foot.
Yeah. Hi, Linda. So nice to see you again. So yes, definitely. So that is the key point. But education is linking with awareness. So because some feeling that I had when I went to any conference and I delivered this kind of lecture is some of the people are very aesthetic, and some people are not believing. So this is the reality, because the people are looking at dressing, right? And at the end there is a dressing inside a bag that you are competing with another dressing inside a bag, and people say, okay, how or why I had to put this one because it's the double of the third time the price to the other. That is the main problem. So and I used to say to Urgo many times, okay, perhaps if Urgostar is injected to the patient or is given by a pill, the people has another awareness, and it's true, because at the end it's a question of local care. And perhaps the first thing is teaching the people about the end of the local care at the beginning of the local treat. So you have to treat, because I don't know what is your feeling, but in my daily practice, I have the feeling that the majority of my patients are not going to heal just with naproxen. And approximately 50-60% are not going to heal. So that is the reality. So for this reason, we have a big bag of patients included in the not healing patient that at the end are not going to heal. So education is crucial, linking this education with increase of awareness and change the mentality about the people not only local care. And for this reason, I started my lecture about diabetic foot is not an ulcer. The ulcer is a sign. The ulcer is a sign. Diabetic foot is a disease. And if we are talking all together, this is a disease, this is not an ulcer, we can think in treat, not only in care. And perhaps this is the problem coming from many, many years ago. And indeed, it's a problem in the Bones Conference. When you are going to Bones Conference, the people are talking about bones, but they're not talking about patient, are not talking about disease. No, there is not an ulcer. The ulcer is a sign of that serious disease that the patient has, and it's a marker of comorbidity, and it's a marker of mortality. So that is time to start and time to act.
Yes, that's what exactly I emphasized during my comment when William finished his talk. Yeah, we have to realize that we have a patient, not a lesion, not an ulcer only.
Thank you, Jose Luis and Linda. Just the last question, what is the limit of ABI to use this product? It has been asked.
So according with the RCT, the limit was 0.7. So below 0.7, you can consider that the people or the patient can have critical limb ischemia. And in this case, it's not recommended to use because you can treat patient without any expectation to healing. So this is more or less the limit.
Okay, thank you very much, Jose Luis. It was really, you yourself saw how interactive it was. Thank you to you, and thank you to Urgo who brought you here. Thank you very much, and we hope to see you soon in other webinars. Thank you very much.
Welcome, and big hug to everybody. Have a nice Sunday.
Thank you. Okay, we move to our third speaker. He has sent his recording because he had an emergency traveling. So he's, I think he's on the sky 35,000 above the sea. Our third speaker is Professor David Armstrong. He's a surgery of University of South Carolina. He's founder and co-director of Southwestern Academic Limb Salvage Airlines. He's a director of University of South Carolina Limb Preservation Program, director to the Stream Healthcare Place. He has produced more than 600 research papers, dozens of in medical journals, as well as 100 books and book chapters, and many other things. He's a co-editor of American Diabetic Association. He was the first podiatric surgeon to become a member of Society of Vascular Surgeons and a first US podiatric surgeon named Fellow of Royal College of Surgeons, Glasgow. He was the youngest recipient of ADA Rogers Pecoraro Award. Armstrong is a past chair of scientific sessions of ADA Foot Councils. He is also a committee member of Infectious Disease International Working Group and many others. So he's a founding president of American Limb Preservation as an interdisciplinary medical and surgical society dedicated to eliminating amputation in US and globally. Today's topic is a journey of barefoot podiatrist to a modern time technology. Ali, can you play his video?
Ladies and gentlemen, it is such a pleasure to be with you today. And I'm absolutely honored to really maybe cover the length and breadth of a problem that maybe we all think about quite a lot over the years. And maybe we could talk about marrying not only team, but with a little bit of technology. And we're going to talk not necessarily just about the diabetic foot in this context, but really what happens in between. And we're going to cover that in a minute. But before we do that, I'll say that you are all so welcome to any of these slides. I would just ask you to ping me, tweet at me, or email me or text me, and you're so welcome. We just ask you that you copy them, you make them better, and you pay it forward. How does that sound? So let's go. And we're going to talk about this now, this sort of big idea, which is not only about what happens after we heal these wounds and these patients who are profoundly wounded, but it's really what happens in between that. How can we maximize the time in between, no matter where we live in the world, and marrying a little common sense with a little bit of humility, maybe with a little technology. How's that sound? So, ladies and gentlemen, this is what I do for a living. I look after people's feet, and as a toe mechanic, if you will, I can think of maybe two great gifts at working on the foot. One I've learned myself, and the other my father taught me, and who is also a foot doctor who passed away more than 20 years ago. And the first is that, you know, in this era of kind of chest thumping and hubris and kind of confidence, I can't think of anything that is more of an expression of humility than looking after someone's feet. This is something that transcends borders, it transcends religions, and if you think about it, even time. Expressions of humility by looking after the foot. This is something that we've seen forever. You immediately put yourself in a position of humility. So that's one great gift that I've found. And the other one is something my father taught me. You know, when you think about it, when you're working on this anatomic peninsula, I was told that the best gift you can give anyone besides your love is perspective. And in working on the leg, you're on this peninsula, as I said, anatomically, and it forces you, and it forces us to sort of collaborate with the anatomic mainland. And that, you know, putting weird ideas and weird people together is what it's all about. And that sort of perspective can be great. Unfortunately, however, that perspective is also problematic nowadays. And let me just show you this, not from nowadays, but from a few generations ago. This is the first video ever caught on tape. This is Professor von Bergman. I've actually been to his clinic in Potsdam, actually, giving and he is doing an amputation, this procedure. And you see this procedure going by so quickly. It's amazing. Look at all the characters here. Look at this guy looks like the fellow. Who am I? Am I an attending? Am I a resident? Where do I belong? Looks like the fourth-year student. Very excited to be there. And that's definitely the quality assurance nurse. She's upset he's not wearing gloves, but I must say very happy that he's turning the room over so quickly. But the learning point here is not that this procedure has just gone on 3 times in the last 30 seconds. It's this woman or this man having her or his leg off to the right of our camera, of our screen, of our vision. And that person, you know, 120 plus years ago, had a better outlook on life, most likely, in terms of quality years ahead of her or him, than someone right now with diabetes having her or his leg off. And that stinks. And I think there's a lot that we can do to improve that mobility and to improve that dignity to try to help our patients. But before we do that, let's talk about all the bad, and then we're going to get into maybe the good. So I don't need to tell all of you that the foot in diabetes, it's common, it's complicated, and it's costly in terms of these complications. It's all very alliterative. If we look in my part of the world, in the United States, I'll share with you some of these data, but these data, thankfully, are quite translatable all around the world if you just think about percentages. So in the US right now, there are maybe 350 million people, about 10%, give or take, have diabetes. Of those, about half have the most generous definitions of peripheral artery disease or loss of protective sensation of neuropathy, as you see here. And maybe there are a couple of million people living with a foot ulcer, living with severe peripheral artery disease, also known as CLTI, or chronic limb-threatening ischemia, or just with frank limb loss. So this seems to be translatable now across the EU, across North and Sub-Saharan Africa, across the Middle East, and the rest of Asia, and even East Asia and Australasia. This is something that I think if we look globally, it's pretty accurate with some modifications in some parts of the world. Let's continue with this global idea, moving from the US to kind of the global burden of disease. And I'll tell you, we did not believe these data when we first looked at them, but this has now been copied in another couple of studies, if we disaggregate the lower extremity from the rest of diabetes, and who doesn't want to disaggregate things? Look at this. It by itself, if we look at World Health Organization's global burden of disease, by itself is a top 10 condition in terms of years lived with disability. This problem is common, it's complicated. And look at these data coming on after that study just a couple of years later. We also looked using similar data in years with disability over maybe a generation between 1990 and the middle part of the last decade. And what we see here is that for every age group, for every complication of diabetes, more or less, these problems are increasing in severity in terms of years lived with the condition and with this disability. So common, complicated. And let's continue with this idea. Let's move now from worldwide to the EU and into France. And we can see even when people have identified pockets where the high-level amputations have reduced, the actual rate of ulceration is increasing. This is extraordinary data from Amadou, if you see this. So it would be like if we were looking at cancer problems, as an analogy, we'd see cancer deaths reducing, but the rate of cancer increasing. This is similar to what we're seeing now epidemiologically, maybe a couple of generations later with diabetic lower extremity complications with these chronic diseases. And indeed, this problem increases mortality. How much? Well, let's look at this. With the best available data that we have, you see here, all else being equal, it's about a 2.5-fold greater risk, at least, in dying that year if you have a wound than if you do not have a wound. Again, all else being equal. Let's continue on with the complexity before we move on to the rest of all this. We see here, if we look at all of the outpatient visits, about 5 billion outpatient visits in the United States over several years, we see that the risk for going to the emergency department, the risk for a referral, the risk for multiple visits is much higher for people with foot ulcers and foot infections than for many of the problems that we know are critically important, like cardiovascular disease, like renal disease, like so many other problems that we know are important as a society. So this is kind of setting the stage for this whole enchilada, but let's continue on with all this now as we look at this and figure out maybe some other ways to talk about this in ways that might help educate not only the people, not only us that are watching this, but maybe the rest of the community. If we wanted to talk maybe to a health minister or to maybe a CEO of a hospital or a health plan, how do we do this? Well, let's talk about second. So now, to the best of our ability, maybe every second now, give or take, someone around the world develops a diabetic foot ulcer. About half of those will get infected. About 20%, give or take, of those infections will end up in hospital, which is why now there is an amputation every 20 seconds around the world. And so what we would like to say is that as a family taking care of these problems, we need to get out there and help in a bigger way. And we believe strongly that time's up. Time's up for a lot of things, but we believe the time's up for unnecessary high-level amputations for these patients. We need to help our patients move through the world better, hopefully with their leg attached. That is the big idea. So let's continue with a little bit more of the bad before we get into a lot of the good, like extending days without ulcers. But first, let's talk about comparing this problem to another terrible problem. And again, it's not fair to compare one terrible thing to another, but let's just do this as a family and as an academic exercise. We all care about cancer. We have all had family members who have survived or have succumbed or are living with cancer, but very few people outside our chat today really care much about diabetes, or especially the foot in diabetes. Come on. But let's just do this as an exercise. Let's first look at cost in North America and the United States. These data are the most conservative I have. We could also go much, much higher, but I wanted to show you the most conservative. Look at this. Right now, and these data are 10 years old. It's actually a little bit worse now. I leave it in because of this. The lower extremity in diabetes is more expensive than the 5 most expensive cancers in the United States. And there are plenty of people right now talking about colon cancer and breast cancer and prostate cancer, lung cancer, leukemia. They should be. But we happy few are the only people talking about that red line that you see at the left of this histogram. Let's have another histogram that is maybe even more important, not only cost in money, but more cost in mortality. If we look at this comparison, again, we see all these different cancers from a 18% mortality with breast cancer all the way to a higher mortality for lung cancer. You see that lower extremity complications of diabetes are at least as bad as a bad form of cancer. We wouldn't think of withholding therapy on someone with breast cancer unless that person asked for it. But yet it happens all the time with foot ulcers, with minor amputations or even peripheral artery disease. The thought is, well, she's just going to get another wound. Why not just cut the thing off and be done with it? Or why not just leave it alone? It'll get better on its own, or something like this. There's this nihilism. And that problem is pervasive and it persists. And let's continue on this whole cavalcade of bad things with cancer. And for people with a foot ulcer, health-related quality of life is equivalent to recurrent breast cancer, in fact, a bit worse than recurrent breast cancer. So all of these things take a giant toll on these patients, not even to mention all the behavioral issues like depression and other issues, feelings of hopelessness. So we have a big opportunity to effect change. Now, let's continue on with some of this, and then we're going to get into the good stuff. Continue on with all of these data that we can share amongst ourselves and our family. Let's look at these data. Very recently, we had this manuscript in the Journal of the American Medical Association that looked at foot ulcers, and we also looked at how these wounds are caused and the etiology. And let's just look at this, because then we can understand how to reduce risk for them if we understand their etiology. So a person with diabetes, generally speaking, will get neuropathy, and that's sort of a tripartite neuropathy. You can get classical sensory neuropathy, which it makes a permissive environment for the wound to actually develop. You can wear a hole in your foot like you wear a hole in a sock or a shoe. You can get motor neuropathy, which gives deformities. So that you get, when you have a foot, I don't know the medical word for jacked up, but you know what I mean, jacked up. You have prominences, both dorsally, plantarly, and even distally. And when the big muscles of the leg overpower the small atrophied muscles in the foot. And finally, you can have autonomic neuropathy, which can make the skin less likely to sweat from moisturizing, and the skin itself, through that and cross-linking, becomes less viscoelastically robust, and therefore becomes maybe a little bit more like a cracker and a little less like a tortilla. How's that for a culinary analogy? And what you see repetitive stress, inflammation, ulcer development. This can be exacerbated by peripheral artery disease, and even in some rare cases, even caused by peripheral artery disease. But you see the development of a callus, and underneath that callus, you have hemorrhaging into the callus, and exposing that is very, very important to show diabetic foot ulcers. Now, we can offload these wounds and help them heal, but what happens after we have healed them? In that context, how are we doing? Should we be hubristic, or should we be more humble in looking at this? I would argue the latter. Not too long ago, we had this manuscript in the New England Journal, where we look not only at foot ulcers and the best available data there, but really at their recurrence. And let me share these data with you. And again, I credit my longtime friend, Sickle Busson, mentor, Professor Andrew Bolton as well. So look at this. At 1 year at healing, about 40% of people are going to get another ulcer in diabetes. It's about 2/3 at 3 and 3/4 at 5. So recurrence, ladies and gentlemen, is not only common in this population, it is darn near likely. So if the foot in diabetes, as we've been talking now for the last few minutes together, is a little bit like cancer, then maybe when folks are healed, maybe they're not healed. Maybe we should take a little bit more humble, broader perspective in this area and call it like it is and talk about remission. This, I believe, is a not only more humble way, but I think is enhanced perspective, the two great gifts I talked about before. This is really important because if we understand that there is a likelihood for someone getting another wound, then it changes the way we communicate with our patient, with health ministries, with really with everyone on the team. When we understand that our goal is no longer to keep to heal everyone, the goal, of course, is to heal them, but it's really to make the recurrent wounds as uncommon and as uncomplicated as possible. Because this problem, again, continuing on with this, is mortal. It increases risk for not only amputation, but mortality. And we have to communicate this. Look at these data from Valdevilu and, of course, from Graham Lees's group. And you see here that folks in remission are at about 9-fold greater risk for death than even for amputation. And so, but the great news is we, anywhere in the world now, can apply good ideas and these data to actually affect change. These, again, are from Scotland, and you see taking data from work from what we've done over the years in terms of classifications, not only with the International Working Group, but with the American Diabetes Association. We can go from low to high, and you see you can even have remission and remission clinics where you can be driving care to extend those ulcer-free days. And let's continue on just with a little bit of these data before we kind of move on for the rest. I don't want you to have to look at this busy histogram, but let me just show you these top 3 conditions for re-ulceration in remission. We know what the top one is. That's neuropathy, 5% perception threshold, the presence of PAD, we know what that is, but also the presence of a pre-ulcerative lesion. What is that? Well, we're just looking at it earlier in that JAMA drawing, but let me just show this with you. It's a callus. And how do we describe this callus, this event that is casting its shadows beforehand? How do we describe that to a patient, to another doctor, to a patient's family, to a healthcare administrator? Well, we all live in metaphor and simile, don't we? No different here. Look at this. If a foot in diabetes is a little bit like cancer, then maybe a callus is a little bit like a breast lump. And that's the big idea here. And if we can get this out there, it makes it a lot easier to start to identify some of these problems beforehand. So now that we've talked about all of these data coming up to this point, we have this idea of a bit of humility matched with a little bit of perspective to try to extend ulcer-free days in remission. How do we do it? How do we prevent severe recurrence if we realize, in the most humble sense, with that enhanced perspective, that we can't prevent all recurrence? And let's do this. We've already been talking about it. Let's kind of put it into action, and we'll talk about data and stuff available to us now, stuff available to us in the future. So in the face of neuropathy, we really have 2 other variables in our equation to develop a diabetic foot ulcer with which we can play and kind of manipulate medically, surgically, mechanically. We have pressure, and we can offload someone externally through shoes, insoles, braces, casting. We can do it internally through physical therapy, or if you're British, physiotherapy, or surgically to change the way a person's foot hits the ground, to give them more steps and less deformity, to spread that force out. But what about the other variable, the third variable in this sort of classical Venn diagram? It's really activity. And it's a pressure activity imbalance, if you think about it, that causes these diabetic foot ulcers. And our goal is to bring that imbalance back into balance. That is the big idea, ladies and gentlemen, as we kind of move forward. This is a slide I've had for so long, for about 30 years. And I used to think as a student that maybe we could dose activity if we can only measure it, like we dose a drug, too high, and you have toxicity, just like with a drug. Our toxicity for this would be an ulcer, too low, and you don't get the cardiometabolic or functional benefit of being active. But maybe there's kind of an area where we can surgically, medically, mechanically ease people back into this. And what do I mean? And how do we do this as a family? Well, look, if we look at these data, this is from Lieberman's lab in Boston, and we see this beautiful pair of legs here. You don't even have to be into feet to say this is just beautiful and balanced. But what are our patients? Are our patients balanced? Unfortunately, no. Their pressure and their activity are out of balance. There's a real imbalance in activity, and that can actually precede ulceration, which could also, interestingly, give us maybe a little trigger to identify this in some of these patients, and we can warn people. And what we've been doing now for some time is we actually, between us and some of my partners in physical therapy, we actually take some of the data that we've done over the last 20 years and we just put it into a simple Excel spreadsheet. We can look and follow people really accurately now with different kinds of activity monitors. This is a pretty slick one that's kind of a pendant mounted thing, but this is already 10, 15 years old. Everyone has a device now in their pocket virtually that can help. And that's becoming more and more available, less expensive everywhere in the world. And now we can just actually plug in a peak and a trough in a simple spreadsheet that's free to be able to identify problems and help warn a patient when they're out of range, just as they would be with their blood glucose. So that's one idea about activity. What about kind of a visual thing? Well, we're all into kind of this solipsistic selfie situation, right? That was pretty alliterative. Hope that's recorded. But what if we could actually turn this into something that was highly functional? And one of my the medical students that has already come through, a resident in Georgetown in plastic surgery, Mark Swerdlow, had been in clinic with us, and we get so many photos, and the goal is really to try to put all this together in one idea, kind of just in just one consistent package. And we actually have developed what we call a foot selfie. And once we get all of these photos, they all go into kind of our Amazon web server in that case, or just upstairs, up into the cloud. They get collated, and then every Monday at 7 a.m. we can manually go through this in what we call foot selfie rounds. And not a week goes by where we are not able to identify a problem and just stop a hospitalization. It is really something, and it's basically free, except for the doctor's time. The rest of this, and maybe a little bit of cloud time, the rest is there, and we can put all this together. And this can be done, we think, at scale or just individually. And then the other cool idea is monitoring healing in this area. It actually works really well, and just consistent photos, putting all this together. And this is getting easier and, ladies and gentlemen, less expensive, frankly. And this is the kind of thing that can scale up all over the world, from Peru to Portugal to Portland, I would say. Let's continue on with this cavalcade of data and stuff over the last several minutes as we kind of go through all this. These are two of my great mentors, the great Paul Wilson Brand, from who spent time in Vellore in India, later into in the United States, working on people with leprosy. I now have it's such a pleasure. I helped attend one of our leprosy clinics, the largest leprosy clinic in the United States, with Maria Teresa Ochoa, almost in honor, really, of all the work he's done. If that's the king of all the insensitive foot in leprosy and in diabetes, then this is the crown prince. This is Professor Andrew Bolton. And that's me. I carry their bags for them. Not his anymore, but this one is high maintenance, as you know. But what did Paul Brand say even back in the day? He said this. He said, wounds will heat up before they break down. And if you guys want to sound smart, and FYI, who doesn't want to sound smart? I am trying and obviously failing, but there is hope for you. Just after this talk, or whenever, even during the talk, put it on mute and just take a sip of whatever you're sipping, and then look over to your buddy and say, inflammation, and walk away. And you know what? You will be right. It doesn't matter what you were talking about. You'll be correct. Imbalances asymmetries and inflammation for every chronic disease is the bane of our existence, and bringing that into some control is the way forward. And we can do this. We can identify this now rather inexpensively just by stepping out of our own spectrum and looking at IR. And this has been available to us now for a long time. It's just getting a lot easier and a lot less expensive. And we can even do this in a clinic. This is just a simple FLIR camera on an iOS or an Android device, and you can see kind of the technology now just being available, and you can show the patient this now. It's a patient with a Charcot, but you can see the same sort of thing and all kinds of other things in terms of asymmetries. The sky's the limit in terms of the uses for alternative vision in this area. Let's kind of continue on that idea, because Paul Brand was right. Almost a generation ago now, that's right. We did a study where we showed that wounds really will heat up before they break down. We can see this even a few weeks before this happens. And we can now put all this together. We can put activity, like we've talked about. Remember, we showed that that dosing activity together with inflammation, which is our sensor. So we can dose activity by checking skin temperature. The thought would be just like we would dose insulin by checking blood glucose. And we have our guidelines that we follow to help do that, to try to highly personalize this for each of our patients, easing them back into activity. And there have been companies that have come around that have done this as well. I'll show you a couple of companies. This is one that developed a smart bath mat and it identified diabetic foot ulcers not hours in advance. That would be pretty good, but in fact, weeks in advance with this tool back then. And you know, the idea is that these things are likely only to get more accurate, not less accurate, even if you're entirely just insensitive at first. A lot of algorithms that we put forward are going to improve this, but the idea of monitoring, remote patient monitoring, is here to stay in some fashion. That is evolving into intelligent textiles. These are so-called smart socks from more than a decade ago, from Bijan Najafi and as lab and the work we've done together. We have thought maybe over the last 15 or 20 or 30 years that we've written about the fact that maybe you could subscribe to your socks or subscribe to your shoes or insoles, just like you subscribe to your Hulu, your Netflix, or your mobile phone. And that idea has been taken forth by other companies. And this is a cool idea, but this is just another, these companies exist and they have great ideas, but many will come, many will go, but the idea is here to stay. This is really, really clever. Ran Ma, the CEO of this company, came up to us after a DEF CON meeting many years ago and said, those socks we've seen from you guys are ugly. We think we could do better. And we talked about subscribing to things. We think this could happen. Imagine now giving someone a pair of socks or 6 pairs and have them subscribe to these with a monitor attached. This is real now. And the other thing that's real is she goes to the Consumer Electronics Show with her team, and they end up winning the TechCrunch hardware battlefield that year against things like virtual reality and augmented reality, and reality wins here. So let's keep on moving into not only from smart socks, let's move on to smart shoes and insoles. This is from Zoltan Pataki from Geneva, or if you're French, Genève. But what we see here is a really cool idea with imagine some shoes and insoles that could get out of their own way. I believe this is a thing. This is one sort of mini shock absorber concept with a capacitor, but you could also do a similar thing maybe with a shape memory alloy or other things. And this is going to be available to us as I think as a family over the coming years. Things like this are already being tested. But what are they? So what are all these tools? Well, let's think about this in a larger way, beyond just the foot, but we have something that identifies a problem like a fire alarm, or a smoke detector in our home, or in and a smoke detector is really important. But what is that if we're living in metaphor and simile for the diabetic foot? Well, it could be something like thermometry or just vision of some kind. That's really important. So you have the smoke. Now, the next step would be to have, maybe a fire brigade, as it were, and we know who that is. The fire department fire brigade is our nurses and doctors and clinicians that can maybe help, or maybe even family members. But what is what's next? What do we need? Well, it'd be nice if in the home we could have something like maybe a fire extinguisher that could immediately put out the fire. Right now, what we have is telling the patients to rest or modifying the shoes. But I think that's an area of significant kind of medical therapeutic and innovation in this area. And I think there's a lot of promise set to happen over the years. Let's now just close with a couple of quick things. Now, let's talk not only about things that are associated with the toe, let's talk about things associated with the flow. And check this out. What if we can marry wearables with injectables? That's pretty cool, right? So this is now a thing. We have been testing these as a team, family over the years. There are now injectable sensors. I'll show you some great work from Natalie Wisniewski, carried forth by our former resident and absolute star, Miguel Montero Baker, who's a vascular surgeon, injecting subcutaneously, and where we can ping for oxygen, but we can ping for a whole host of other analytes in this area from a distance during a procedure. Imagine that, to have a plexed out series of sensors in a body, and you're kind of modding your body. This is just the coolest thing in the world. What else can we do? Well, what else is available? Well, there are, and there have been now, intellectual property, and for some years now, in smart blood vessels. Check this out. Imagine pairing with a blood vessel. This is a PTFE, a Gore-Tex blood vessel on the back table in the operating room, or operating theater if you're British, just like you'd pair with a set of headphones. And then looking, after that's been implanted, for turbulent flow. You wouldn't have to have a person back frequently necessarily for looking for that turbulent flow, because the fact of the matter is that nothing ruins a good repair, a reconstruction, like follow-up, and eventually either the patient's going to go down or the repair is going to go down. Wouldn't it be nice to be there before it happened? This is the idea for this. Now, this is just good for maybe short segment, kind of proximal, or I should say short segment stenoses, really kind of proximally. But imagine now for other areas. I think this is exciting, frankly. Ladies and gentlemen, where are we leaving ourselves? Well, we're leaving ourselves kind of where we began, maybe with a little bit of humility married with some perspective. And I'll add this in by request. I was given this by the late great Peter Sheehan. It made me laugh almost 20 years ago, so I'm going to bring it back and share it with you now. So let me just show you. I'm going to set this up for you. I think this is East Africa, if I'm not mistaken. And I am not a wildlife biologist, but I believe that's a giraffe. And this is for sure a gazelle. I don't know, Grant's or Thompson's, something like that. But kind of running fast and a small cranium. That's a lion, I think. And kind of relaxed, chillaxed, knowing where to be. Running fast, not thinking, relaxed, sort of chillaxed, and boom. And this guy and his buddy are going to have kind of a mid-morning kind of East African brunch at the expense of the gazelle. And this just made me crack up. Back in the day, I thought to myself, after I picked myself up after laughing, I said, man, that's me. Definitely not the lion, but maybe the gazelle. Maybe not as fast as the gazelle, but maybe not thinking. Maybe just running and just saying, don't just stand there, do something. Make her NPO, get him into the hospital, write that order, don't just stand there. And and as I was thinking of that, it made me sort of flip the script and think of this guy, and this is Charles Dodgson, also known as Lewis Carroll, who back in the day flipped the script in Alice's Adventures in Wonderland by way of the White Rabbit. And he said, don't just do something, stand there. And I think if we stand there as a family, and we regard what we have done. What we've done over the last generation or two now in this area, there's been a lot of good, but there's a lot that we need to improve on. And that's why it is the practice of medicine and surgery and nursing. And that's why this is a concord with our patients. And if we can move forward and help our patients move through the world a little bit better each and every day and keep a few more legs on a few more bodies, well, you know what? That's worth a life's work. And here's to that. Here's to you. And here's to the greater family in this area and making a difference. Thank you very much. It's been an absolute pleasure.
Thank you very much, David. You will all agree there was another great lecture by David. As always, he is a great speaker and emanation and all these things. He started with a remote amputation by saw, and he ended up with a hi-fi technology in diabetic foot. I'm also thankful to show you, this was a clip from Tanzania, Serengeti Park. That's a nice one that he ended up with. He's very nice of him. He has sent me a WhatsApp number, and he told me, I'll pick your WhatsApp number if there is any burning question to be asked. But I think we will leave him and just send his thank you very much for what he has done. I now, and you will all agree, it was a great session, all three talks, thank you to all three speakers. I will give to President-elect for giving a vote of thanks.
Thank you, Abbas. I think, firstly, I would like to take this opportunity to thank Dr. Abbas and the whole board for actually what you call is coming up with this awareness program, which is actually a flagship of the DFU International. At the same time, I would like to thank the regional chairs and all the regional committees basically for coming in to support, and our great speakers. I mean, William Jeffcoat and Jose Luis and also David Armstrong. And just to echo what Abbas has said just now, I've actually WhatsApp David with some of the photos and told him how wonderful it is. He's quite happy. He sends his regards. He sent a huge big love actually. And so he's happy with the sessions we are having. And I think I would like to thank Ali, our secretary, who's been helpful in this program. And last but not least is our supporter, also our strong supporter, which is Ergo. And Ergo has always been, strong supporter of DFood International. And I would like to thank the delegates because it is a Sunday, it's a public holiday in some places and also celebration in different places. So I think it's a great effort by them to actually come in at all the different time zones from all the 7 regions, basically. You see, Linda, Mariam, Roberto, Vilma, everybody's around, Zaid and myself all from here, Jamil from Middle East. So, and then Christian is also here. So it's a great session with Kulapa and Maimuna also. So I think with that, thank you very much. And we look forward to the next session tomorrow on the 13th and also the 14th, where we have the Western Pacific region. So thank you again. Have a great, wonderful weekend. Thank you very much. And see you tomorrow if whoever wants to attend. Thank you very much. I really appreciate it. Thank you. Bye. Bye-bye. Take care.